So after hearing these two literally very foundational talks about the whole landscape of genomic architecture which is happening with prostate cancer and what the molecular subtypes are, I'm going to focus a little bit about how can we apply that information as clinicians and a little bit of a surgeon scientist mindset into understanding the racial disparity of prostate cancer. Amongst the risk factors which we know about prostate cancer, African Americans do have a greater incidence of prostate cancer, and they tend to do twice poor mortality when they are diagnosed. And it's not just happening in United States. Presented here in this part is the worldwide data about the mortality and incidence, and African Americans, even in Africa and most importantly in Caribbean, have the highest mortality of prostate cancer. Our institution, our program has got multiple hospitals, so we do have a significant proportion of men of an African American descent who interact with our program. So that gives us an opportunity to understand and go a little bit deeper dive into this. We recently put together a thought process, and we thought there are a combination of things which are happening. One, there could be a genomic, there could be a molecular, there could be an inherent predisposition for A, getting cancer, and B, having a cancer act more aggressively. Second thing, we noted that the comorbidities which persist amongst an African American population, like metabolic syndrome, diabetes, inflammation, that itself can make an existing cancer behave more aggressively. And lastly, but not the least, healthcare seeking behavior may have a difference as to when and how they get diagnosed. In the earlier part of my career, I was in Detroit, and 40% of the patients I used to treat were African American. So I had a chance to look through that data, and I will come back and sum up my talk with that mindset. So we thought, how about we start looking at what are the fundamentals of the molecular biology and the genomics, not going as much of a detail, and I'm glad that you got an exposure to as to what's happening, to see how it applies to an African American race. Any cancer, and for that matter, prostate cancer, becomes cancerous because at some point cells started behaving more aggressively. Basically, they are dividing more. And that's an oncogenic phenomena where certain genes, which can be clustered as an oncogenes, are giving a signal to a cell to divide more and more and more. So we can focus our thoughts on our oncogenes, which are more proliferative. The second set of process or second set of genes are the one which are normally supposed to put a brake on the process, and these are known as tumor suppressor genes. P53, you were listening many times. RB was the one. P10 is another example. Then there are other mechanisms by which cancer cells become more aggressive. One of them is an epithelial to mesenchymal transformation, where cells really regress back to their primordial form and becomes more invasive. There is a role which inflammation plays into this entire process. So I will try to kind of put my thoughts into different clusters. By the way, this slide has been put together by two of our PhDs in the lab, Kamlesh Yadav and Sujit, and it kind of, at least for a year ago, had most of the genes which were implicated in prostate cancer were summarized here. So let's go to the African American specific issues. So one thing which came out, and that I think came out of a paper which Chris Barbieri wrote, that SPINK1 is more frequent amongst African American, and P10 and ERG and SPOP mutations are less frequent. Is that still holding good with your data? So, meaning, things evolve. Every time you add in 100 more patients, data looks different. But what is standing out, that there may be different pathways active in a particular racial group. So it's important for us to know that this precision medicine, approach which we are taking may have an impact the way we are treating our patients. There are differences even when the location of prostate has been analyzed. There are anterior tumors, and I personally think that anterior tumor tends to be more common amongst the African American. And the data says that they are less androgen receptor susceptible. The global expression of androgen receptor is lesser in an anterior tumor and more is in SPINK1 and all those things. So there is something happening, that there is a molecular difference and there is a racial difference in the location of the cancer. And in my cohort, at least 15 to 17% of the patients do have an anterior tumor. So this is something we have to look into it and understand, is the reason for cancer in an posterior versus anterior different, and that's why the biology is different. Of course, after Charles Huggins' work, everyone focuses on the androgen receptor axis and how it impacts the prostate cancer. And this is again a slide put together by Kamlesh in which he thinks androgen receptor is in the center of most of the bad things which are happening in prostate, including the cell proliferation, how the immune evasion happens, and all those things. So androgen receptor and androgen metabolism tends to be different amongst two racial groups. African Americans, when they're young, they tend to have a higher peak of androgen in the body. But as they age, the important part is there is a much more dramatic decline in androgen levels, and that may have an impact. The cell which was used to of having an X amount of androgen early on now is deprived of that. How it reacts is what we need to understand, but there is a difference in the proportionate decline in the testosterone amongst the African American men. When androgen comes to the cell, in order for it to do something, it has to convert, and after conversion, it has to react with the androgen receptor itself. There is a part of androgen receptor which is known as CAG repeat. Imagine CAG repeat is like a lock. Shorter it is, easier it is to open. We found that African Americans have a lower than 16 or 19 CAG repeats, essentially meaning they have a little bit loose lock. So even a lower amount of testosterone, if it's existing in that surrounding, it will switch on the androgen receptor activity. So the CAG activity, and also similarly there is an SRD5, which is another version of how to activate testosterone to dihydrotestosterone, is also different amongst the African Americans. We talked about the inflammation, and I do believe inflammation as such is a big promoter of prostate cancer. We heard yesterday, Siddhartha Mukherjee was talking about as to how the soil changes and what impact it can have on the carcinogenesis. NF-kappa B, which is a central part of this inflammatory process, cytokines, they all tend to be a little bit hyperactivated amongst the African American. There was a study done from the West Coast, not looking essentially on the prostate cancer patients, but on the Alzheimer's. They found African Americans did have higher levels of C-reactive protein, a surrogate marker that they have a more inflammatory process going on in the body. So we are not just talking about inflammation within the prostate, we are talking about surrounding inflammation in the body. And there is something to suggest that there may be more inflammation amongst African Americans. You can get down to an immunohistochemistry level of analysis, and you can find the inflammatory cells more often present amongst the African American analysis. We talked about tumor suppressors. And sometimes cells are supposed to kind of suggested that, okay, you have done enough, you're no longer viable enough to survive. If we let you survive, you will go and become cancerous. You need to die, and that's the apoptotic pathway, which is built in our cells, and that's why there is a balance. There is a difference in the tumor suppressors and the apoptotic process, which kind of is suggesting cells to continue dividing when they are no longer fit enough to continue going into the cell cycle. And that entire process tends to be more aggressive amongst the African Americans. Then cancer journey is an interaction between the clone of cells of our own which have become more aggressive, want to take over our own body, versus a fight which happens with the surrounding cells. And that's known as an interaction between the tumor microenvironment and the cancer cells. There is a clonal evolution happening between the cancer cells and an interaction with the surrounding body's own fibroblasts to white cells and different kind of cells. So there is a suggestion that there may be a difference in the tumor microenvironment, and the data suggests that autocrine, mobility factor receptors, chemokines, and matrix metalloporphyrin 9, basically what it's saying that the chances of invasive behavior to bury through a hole to it become an extracapsular extension is more present amongst an African American prostate cancer when you get a deep dive into the tumor microenvironment. There are data to suggest that amongst the African American, there is a more stromal-derived mediators of inflammation, which may be making his cancer more aggressive. Then comes an issue about tumor mutational burden. Amongst scientists, there is a major discussion that prostate is not that mutational cancer. Pancreatic cancer is, and other cancers are. Prostate is not that mutational, meaning for the number of mutations which exist in prostate cancer to become prostate cancer is not that impressive. A, it has an impact on that how you can diagnose. B, it has an impact on how can you make a targeted therapy against it. And C, it has an impact on higher mutational burden, sometimes becomes so annoying to the surrounding T cells that they start mounting an attack. So it becomes a potential target for an immunotherapy. So African Americans tend to have higher mutational burden. There are protein coding mutations, as you can see on the right side, they are higher. Deleterious mutations are higher, and oncogenic drivers are higher. So all said and done, they have a little bit higher mutational burden that could be perceived as if they have more aggressive cancer. But in my mind, that opens up a totally new door for us to explore that they may be a better candidate for immunotherapy approaches which are happening as we talk. We also talked about that there is a clonal evolution which is happening in cancer cells. A cell becomes cancer when body tries to mount an attack, things are not favorable. It does another set of a mutation. So that evolution goes on, and we call it truncal in the beginning when it became cancer, and branch when it is slowly evolving into a different subset. So there are differences in which how these things are happening in single nucleotide variant versus insertion or a deletion of a particular part of chromosome versus a total difference in copy numbers amongst the two chromosomes. They tend to be different among different racial groups, and as we look at the clone versus subclones. Then we talked about finally, things have to really get worse for that cancer to invade and metastasize. And tumor becoming a very primitive cancer is known as an AMT process, and it is mediated through a gene pathway, which I still remember. We were talking about snail pathway about 6 years ago in an operating room. He was the PhD, and he was trying to teach us, and he was on a console trying to drop something, and I said, okay, if you tell me about snail, we will go over. So Chris and I have been working on it for a long time. Bottom line is there are certain genes which mediate process of epithelial to mesenchymal transformation, and they tend to be more aggravated amongst African Americans. All that is done, we inherited something, something happened within the gene, but there are things which through inflammation, through our lifestyle, through our diet, can change expression of these genes. Imagine there is a DNA and it is surrounded by something, and that is known as an epigenetic phenomena. I'm simplifying too much for my rest of the colleagues who are clinicians, but epigenetic changes can actually express or not express certain handicaps which may have been inherited or developed. So there are that's known as the methylation studies, and we did this analysis ourselves here. This paper has been published. We basically found there is a Wnt canonical pathway which was much more active amongst the African American. There is a brighter side to this thing, that you can change the expression of your gene by managing your lifestyle so that the epigenetic expression doesn't happen. You can see on the left and the right, there are two different kinds of an epigenetic expressions, one for the Caucasian and one for the African American. So something is happening at an epigenetic level. In order for DNA to do something, it has to create a protein, and in between comes the microRNA. Think about DNA as a pen, and microRNA is a cap of that pen. Those microRNA can block certain things, and those are different amongst African Americans. All said and done, there are two different kinds of DNAs within a cell. One which is in the nucleus and one which is in the mitochondria. Previously, they used to say that the mitochondrial DNA only came from the moms, but I think things have changed, and that fathers also can contribute a little bit of a mitochondrial DNA. But there is a certain aspect to the mitochondrial DNA is that it is no longer a double helix. It's a circular DNA. And it's a DNA which is within the nuclear reactor. All the energy metabolism is happening within the mitochondria, so they have much more exposure to certain chemicals which can cause mutations. And even in one cell, there may be mitochondrial DNAs which may vary between the two mitochondria. So bottom line is mitochondria can also contribute and can contribute to the Warburg effect, which is being talked about, the diet and exercise discussion, and that tends to be different amongst African American. So almost every pathway which is possible to lead to prostate cancer has some differences. We talked about the immunological aspects. They tend to have a more immunologically safe profile. We talked about the mutational profile of the aggressive prostate cancer. Their mutational burden makes them more likely to respond to immune responses. This is the data done at our own place with the Allies group. We collected about 600 patients who were African American and 1,000 patients who were which were white American, and this is a study which is going on. Paper is yet to be written. So I would summarize here from a molecular standpoint, there are differences in the androgen axis. There are differences in tumor microenvironment. There are differences in the apoptotic pathways. There are differences in the inflammatory genes. And all that combined somehow gives us a poorer outcome. So what? This was a paper which I wrote when I was in Detroit. And I looked at the data amongst African Americans when they had conservative treatment versus radical prostatectomy. They were adjusted for comorbidities, they adjusted for the overall health status, and we also had a large pool of patients who didn't have prostate cancer, and the study was put together. Bottom line was, when African American patients, they got an aggressive treatment right in the beginning, their survival was not much different. That's the actionable idea in my mind is there is a difference in a molecular pathway. There potentially could be a difference in how they become cancerous. But if we find that cancer early enough, there is a possibility we can have the similar kind of an outcome as we can get into any other racial group. And this is what we propose. A pathway to victory is do an African American specific molecular analysis so that we really understand the biology. We can come up with the recommendations as to what they can do on a day-to-day basis to reduce that so-called handicap. I'm not sure if there is a real handicap. Then showing up for cancer being diagnosed early. Still within US Preventive Task Force saying that African Americans should be screened, it's not that common. And finally, having an immunological approaches to possibly treat these cancers may be an exciting opportunity. Thank you very much.